Good evening, everyone, and welcome back to the Grand Round sessions. This is a month again, we are examining the future of cardiology, and I'm hoping you will continue to enjoy this series, this fall series. Before we get started with today's session, let me go ahead and present to you some of the essential points about how you would get the CME and the MOC credits. So as you would know that cardiology grand rounds continues to be recorded and stored at the division website in the Division of Cardiovascular Diseases. The series is called as Back to the Future of Cardiology. You can get the previous recordings there, which are available within about 12 hours after they are completed. So please feel free if you have missed any of those recordings to go and hear them because they are being presented by some of the national thought leaders in their specific fields. We have CME credit, and for this particular session, now is the time to go ahead and text 12448 to the number 888-816-4893. 12448. Please text to 888-816-4893 in form of an SMS message. And you would need to have an active profile in the Rutgers Cloud CME, and you must have your mobile number registered and matching from the number that you are texting from. And for also the physician, we have the MOC points. For this, you'll have to complete the first step for the CME. And after that, there's a link that is here provided. This will be available also in the chat as a text message. You will be able to link on it and go and enter a room code, which is called as Future 06. Future 06. Once you enter the code, you are able to answer the questions which will follow the CME event. And if you answer it correctly, then you will have credits in terms of MOC points that will go directly into your ABIM website. And for this, you would need to have your date of birth and ABIM website ID address registered within the Cloud CME profile, without which you will not be able to get the MOC points. And it's important that these steps can be availed for almost 12 hours after the broadcast is completed. It will be open for acquiring some of the MOC points. And also the website should be uploaded simultaneously for you to be able to observe the recorded event. Now, without further ado, it's my great pleasure to introduce the speaker for today's Grand Rounds. It happens to be great colleague, friend, Dr. David Messica-Zuten. David, welcome. Dr. Messica-Zuten is a professor of cardiology, currently practicing at University of Ottawa Heart Institute in Ottawa. And he has had a prolific career in cardiology, particularly in imaging and valvular heart diseases. He did his initial training in France, where he earned his diploma and doctorate at the University of Paris. And interestingly, we were together as research fellows at Mayo Clinic, where we happened to meet not only us, but also we had in common a friend, Dr. Grace Versosa. And I have a story here that Grace actually gave her car to David, right, after she completed her research fellowship. So, and that car has its own history with David. Anyway, so after completing his research fellowship at Mayo Clinic, he went back to Paris and became a professor of cardiology in 2013, and then went and joined Ottawa Heart Institute, where he focuses on different aspects of valvular heart diseases. And he has an extensive research that spans from genomics to phenotyping of valvular heart diseases using imaging. And I just learned that he has developed a biobank, and I can see his interest in applying new technologies. I was going through his interest in ultrasound to even machine learning and deep learning that he's applying to examine the field of valvular heart diseases. And he has extensive funding record from state and industry sources to really increase the throughput of the research that he's doing. He's very well known worldwide for his research work. He has over 100 peer-reviewed published articles, and he's also an associate editor of European Heart Journal, and thereby he contributes extensively to the growth of the knowledge that is going on in this field. And I thought it'll be a great exercise for us to have someone like him, who is both not only himself doing the work in the field, but also as an associate editor of a journal, examining and seeing what's happening in the field to tell us what's the future of cardiology going to be in the field of valvular heart diseases. And along with him, we are also delighted to welcome our discussants for today. Happen to be local leaders, and they are themselves distinguished in their own ways. Dr. Saba Bhatti is going to join us. She is the Associate Professor of Medicine and also the Director of Echo Lab at Rutgers Robert Wood Johnson Medical School. And along with Saba, we will also have Dr. Ankur Sethi. So Saba comes with the background of imaging, and Dr. Ankur Sethi is Assistant Professor of Cardiology and has recently joined in the last few years to become a force in structural heart interventions, is in a very busy program here in New Brunswick. And I thought he will come along with Saba and we can all discuss the field, where is it going. But before we go into the discussion, we'll invite Dr. Masika Zuten to give his talk on the future of valve heart disease. David? I think you're muted.
Always forget. Thank you, Bato, and colleagues. A real pleasure to be here. Thanks again for the invitation. So let me start to share my screen first. Do you see them?
Yes.
It should be full screen. Okay. So I've been asked to discuss the future of cardiology and specifically focus on valvular heart disease. Here is my disclosure slide. To start, people like Stephen Hawking can argue that the future is very difficult or cannot be predicted. And one reason for that is that we are building the future. So we shape the future. That's maybe why it's so difficult to predict. What I would like to show and share with you today is what are the unmet medical needs in valvular heart disease that I would like, and I will discuss how to fix and in order to improve the outcome of patients with valvular heart disease. First, you all know that valvular heart disease are disease of the elderly. You have seen multiple times this pyramid of ages. We are in that kind of situation, and we will evolve where the majority of the population will be elderly in the future. If you look at specifically in Canada, we are currently with 7 million of people more than 65 years or older, and in 40 years we expect this population to grow to up to more than 12 million. And the prevalence of valvular heart disease increases with age. It's overall 4% when you are in between 65 and 74, and increase up to 11% when you are 75 years old or older. And as you know, the two main valvular heart disease that we are facing now are aortic stenosis and mitral regurgitation. If you want to assess what is exactly the prevalence of the valvular heart disease, you need to do epidemiologic studies like the Oates valve. In this study, they screen from primary care 2,500 individuals that were referred to the primary care, and they did a transthoracic echo. And they found that using the rate of valvular heart disease they found in the screening program, that the number of patients in the UK with moderate or severe valvular heart disease will increase from 1.5 million in 2015 in the UK to more than 3 million in 2026, so more than double. Nordic countries are also very famous for their registry. In this Swedish registry here, they were able to capture the entire population of Sweden, so more than 10 million of individuals, and look again at the prevalence of aortic valve disease and mitral valve disease in the population. You see again that the prevalence of aortic stenosis and mitral regurgitation increases with age, and you see how dramatic is the increase as population is aging. We have aortic stenosis, we have mitral regurgitation, and we have the COVID-19, but we have also a new emerging valvular heart disease in Western countries. We have the CMVD for calcific mitral valve disease. We have tricuspid regurgitation, and we have AMR for atrial mitral regurgitation. And I would like to show you more data on this emerging valvular heart disease. Calcific mitral valve disease is a disease where the mitral annular calcification extends into the mitral valve and can cause mitral regurgitation, mitral stenosis, or a combination of both. In this study, we collected 167 patients that were diagnosed in our echo lab with calcific mitral valve disease, so either mitral regurgitation or mitral stenosis or a combination of both due to calcification. What was interesting is to observe that majority of the patients were symptomatic, and only in the minority of the patients that were symptomatic, so despite a class 1 indication for doing an intervention, were conservatively managed. So most of the patients with calcific mitral valve disease remain untreated. And it's going to be more and more frequent. In this study, we collected more than 11,000 people that had at least 2 echoes performed in our lab, at least 1 year apart. You can see that if you start with mild or moderate MAC, in 10 years, 1/3 will develop severe MAC. And if you start with moderate MAC, 71% will develop severe MAC. Interestingly, the prevalence or the rate of progression was higher in women than in men. And if you look now on the progression from MAC to calcific mitral valve disease, which is really the disease, MAC is just an epiphenomenon, you can see that the rate of development of calcific mitral valve disease is overall 10%, but when you have severe MAC, which is quite common, the rate is much higher, around 60% at 10 years. And you can see again that this progression to calcific mitral valve disease is more prevalent in women than in men. And the issue with calcific mitral valve disease is that surgery is high risk, and surgeons refer to the mitral annular calcification as the bar of death. And we have limited options from transcatheter therapies that we can discuss later on, even transcatheter mitral valve replacement with the risk of LVOT obstruction and embolization. Second emerging disease is tricuspid regurgitation. The prevalence of TR has been refined in this study from the Mayo Clinic. They have observed that the prevalence of TR in the community is 0.55%. You can see again the marked prevalence of TR with aging. And interestingly, the prevalence of TR was higher in women than in men. And if you compare the prevalence of tricuspid regurgitation with the prevalence of aortic stenosis, they were very similar. The third emerging valvular heart disease that we are facing is atrial mitral regurgitation. We used to divide MR as primary MR due to abnormality of the leaflet or the chordae, and functional MR due to abnormality of the left ventricle, either due to ischemic or dilated cardiomyopathy. However, main determinant of the dilatation of the mitral annulus is not the left ventricle, is the left atrium. In this study, we collected patients with various diseases with different degree of LA and left atrium and left ventricular remodeling, with patients with atrial fibrillation, secondary MR, primary MR, and mitral stenosis. And you can see that the best correlation between the size of the annulus and the cavities is with LA and not with LV. And so we have to revise our nosology regarding mitral regurgitation. We have what we call now ventricular MR, when you have the LV remodeling causing the tethering and the traction of the mitral valve, and you have atrial functional MR, which is due to enlargement of the LA, enlargement of the mitral annulus, and functional MR. And it's often seen in patients, but not only, with atrial fibrillation. And the prevalence of this atrial functional MR has been evaluated again by the study from the Mayo Clinic. They collected 727 patients with moderate or severe MR in the community. 1/3 had primary MR, 2/3 had functional MR. And overall, the rate of ventricular and atrial functional MR were relatively similar. So 1/3 ventricular MR, 1/3 atrial MR, 1/3 primary MR. And this atrial MR is related to AFib, and we know that the prevalence of AFib is dramatically increasing. If you look at the prevalence of AFib in the elderly population, which is the population where we see valvular heart disease, it can be as high as 20 or 25%. So because of the conjunction of atrial fibrillation, we may see more and more of patients with both atrial functional MR, but we know that also atrial fibrillation is a cause of functional tricuspid regurgitation. So clearly, valvular heart disease is the next epidemic. For a long time, we have thought that aortic valve stenosis and other valvular heart disease were a degenerative process, so wear and tear phenomenon. But we know now more and more that they are not passive, but an aggressive, active phenomenon with active regulation. If you look at AS, we have now a better understanding of the pathophysiology. AS involve endothelial damage, inflammation, lipid deposition, and lipid oxidation. You have cell differentiation with osteoblasts and production of this bone matrix. Despite the relationship between aortic stenosis and hypercholesterolemia or lipids, 3 randomized controlled trials have shown that statins has no impact on AS progression. There have been also some indirect relationship between burn turnover and progression of aortic stenosis, meaning that patients with osteoporosis may have a higher progression of AS. In this study recently published from the group from Edinburgh, they have randomized patients against placebo using bisphosphonate or the denosumab, which is an anticalcified agent acting on the wrong ligand pathway. They have enrolled around 200 patients. Mean age was 73, 21% only were female. Bicuspid valve were 7%, and overall the degree of severity was moderate with a mean gradient of 23 and degree of calcification of 1100s. They have shown that both the denosumab and the bisphosphonate had an action on the burn turnover with a decrease in the C-terminal telopeptide. But unfortunately, none of the 2 active drugs had an impact on AS progression, either assessed by echo or assessed by the CT calcium score. We have also made some progress in the understanding of myxomatous mitral valve. We have identified some of the genes, but overall, our knowledge remains limited, and there is no medical therapy that can prevent the progression of valvular heart disease. And the only treatment we have available so far is a valve intervention, either transcatheter surgery, or can be a valve replacement, or can be a valve repair. What happened to this patient if you don't treat them? They die. And you can see in this partner high-risk subset that the mortality of patients with severe aortic stenosis, severely symptomatic, can be as high as 70% at 2 years. So clearly, valvular heart disease are lethal and if left untreated, and there is no medication that can either prevent or stop the progression of valvular heart disease. But we have new and less invasive therapeutic options that are transcatheter therapies. In these studies, we collected all aortic valve replacement performed in France between 2007 and 2015. And you can see there is a marked increase of number of aortic valve replacement performed between 2007, around 11,000, up to 18 to 19,000 in 2015. And this linear increase is due to the increased number of TAVR performed up to 7,000 in 2015. We have updated that up to 2019, and the paper is under publication at the European Heart Journal. And you can see that we haven't stopped growing. So question is when the number will stop and or plateaued. Now it's in France, all AVR is 25,000 in 2019. And again, it's due to the marked increase of TAVR, while the number of surgical aortic valve replacement in blue are declining. And the TAVR implementation has been first as a complementary treatment. TAVR has enabled us to treat patients that were denied any intervention previously. And now both TAVR and SAVR are competing for the same patient. And TAVR is now a method of substitution against SAVR to treat patients with aortic stenosis. So transcatheter therapies have clearly revolutionized the management of patients with valvular heart disease. If you want to manage correctly your patient with valvular heart disease, you need to do first correct screening of your patient. You need to identify the patient with valvular heart disease. You need to carefully follow your patient and perform a timely intervention in a centers which provide a good outcome. Are we doing good in clinical practice? The answer is no. If you look first at this survey where they interrogate almost 9,000 people more than 60 years or over, you can see that most of the patients are not aware of the importance of valvular heart disease. It's far below cancer, Alzheimer's disease, or stroke. And if you want to identify and screen for patients with valvular heart disease, one of the first steps is probably the most cost-effective way is to listen to your heart of your patient. And if you ask patient how often your GP is listening to your heart, in more than 50% is quite rare, and auscultation is seldom performed in the setting of GPs. In this survey, instead of asking patients, they ask physicians. So they interrogate more than 500 physicians. They were GPs, cardiologists, and subspecialty cardiologists or surgeons. And they ask these 500 physicians regarding their knowledge, skills, and practice. And you can see again, if you ask the family physician, they don't listen to the heart of their patients. And we know that is bad because the Oxval study have presented before. If you do a systematic echocardiogram, you will find a significant number of patients with valvular heart disease. So not listening to the heart of the patient is a missed opportunity to diagnose valvular heart disease. So clearly, valvular heart disease are underdiagnosed. They are underdiagnosed, but also they are undertreated. In this paper from the Mayo Clinic, they collected almost 1,300 patients with a diagnosis of mitral regurgitation. They were all living around the Mayo Clinic. They were all have access to the Mayo Clinic care, so access was not an issue. And what they found here is that despite a class 1 indication for surgery, only 1/5 of the patients that were diagnosed with mitral regurgitation that had an echo done performed and with a report sent to his family physician or cardiologist, only 1/5 of the population underwent a mitral valve surgery. We look at that as well in France. We collected all admission in 2014, 2016 performed in France. We collected more than 100,000 of admissions with mitral regurgitation. You can see that most of the patients were conservatively managed. 92% were conservatively managed, and only 8% underwent a mitral valve intervention within a year. You can see also that the population were quite old. 50% were 80 years old or older, and 12% more than 90. And the outcome of this patient, where they were conservatively managed, is poor. 1-year mortality, 14%. 1-year mortality or readmission, 2/3. 1-year mortality or readmission for heart failure, 1/3. And it has a significant impact on cost. We looked at admission and readmission. In average, patients were readmitted twice. And we calculated that the total cost of MR per year were between 400 million to 600 million US dollars. Huge cost. What about AS? I was fortunate to lead this multi-center registry on aortic stenosis. We collected more than 2,000 patients with severe AS between 2015 and 2017, 23 centers in Europe, 9 countries. What are the results? The main result of the study was to show that most patients were elderly and half of the patients again were more than 80 years. Frailty and comorbidities were very common and often multiple. That patients were still referred late in the course of the disease with severe symptoms and or LV dysfunction. And critically, despite availability of TAVR in all these centers, more than 20% of patients were denied any intervention despite being symptomatic. What about TR? We collected in this study more than 17,000 of patients admitted in France with a diagnosis of TR between 2014 and 2015. Mean age was 75, 22% had a prior cardiac surgery, half of the patients had concomitant MR, 29% ischemic or dilated cardiomyopathy, and half of them were in heart failure. And you can see that only 20% of this population had an intervention, and half of them, so 10% of the total population, had a tricuspid valve intervention. If you look at a specific subset, patient referred for mitral valve surgery within a year. So the patient has been referred for a mitral valve intervention and they had significant TR. And you can see that despite significant TR, in one third of the population, TR was neglected and no intervention was performed despite significant TR and the patient referred for mitral valve surgery. And the prognosis of patient conservatively managed, again, is very poor. In hospital mortality, 5%, one-year mortality, 18%, and 41% were either readmitted or dead for heart failure. And this is true overall, but it's also true even in isolated TR, patient with no prior history of cardiac surgery, patient with no left-sided valvular heart disease. You can see that the prognosis is very similar. And despite this high prevalence, despite the significant impact on TR outcome, the number of valve surgery performed for TR is ridiculously low. From the STS, you can see that the number of isolated tricuspid valve surgery has increased over time. It's only 300 in 2004 compared to only 800 in 2013. And interestingly, despite this increase, mortality rate has remained very stable, around 10%. We look at that as well in France. Number of isolated tricuspid valve surgery performed in France is only 120 per year. And we find again that the mortality rate was 10%. To further refine that, we collected all tricuspid valve intervention performed in France between 2007 and 2017 in 12 French centers, which in average represent half of the surgical volume in France. You can see that as shown in the STS, we have an increase in the number of tricuspid valve intervention performed in France, but the number are very low when you compare that to the prevalence of TR. Number of isolated tricuspid valve surgery among these 12 centers, around 50 per year. And we find again that the mortality of isolated tricuspid valve surgery is 10%. However, this 10% was hiding significant disparities. You can see that the mortality for patients with prior left-sided surgery is 16%. Mortality for organic TR due to endocarditis is only 5%. And when you perform a multivariable adjustment, etiology or mechanism was not an independent determinant of outcome. What was predicting the outcome is the severity of the clinical presentation. So we should shift our paradigm. The mortality, 10% mortality observed in isolated tricuspid valve surgery is not due to a complex surgery, is only due to the fact that patients are referred very late for an intervention. So clearly, valvular heart disease are undertreated and patients are still referred late or too late in the course of the disease. And you have seen the survey among GPs. What we need also to improve is knowledge. You can see that physician had an insufficient knowledge both regarding the evaluation and the management of patient here with MR, but also true for other valvular heart disease. And there is also inequity. we looked at the total number of mitral valve surgery performed in France in 2014 to 16. We collected 18,000 patients with mitral valve surgery, both DMR, degenerative mitral regurgitation, and secondary mitral regurgitation. And we have found that the outcome was not great. Even for degenerative MR, 1 year mortality at 1 year was 13%. It was 25% mortality rate at 1 year for secondary MR. And the prognosis was even worse when you perform a replacement compared to repair, or if you have to do a combined intervention. If you look now specifically of patients with degenerative MR, in the best subset, patient less than 60 years, no comorbidity with a Charlson score of 0, you can see that overall rate of repair was suboptimal. And significant disparities against sex. 89% in male, only 65% of repair rate in female. Another inequity was the rate of repair in elderly patients. Only 64% of patients with no comorbidities, more than 75 years, get a repair in France. And this sex disparities has been also confirmed in AS in this paper from Quebec. They clearly showed that even after adjustment, the prognosis of women is significantly worse than the prognosis of men. And one possible reason for that is that women were less referred for an intervention than men. So there is inequality in the quality of the valvular heart disease treatment that is provided to our patients. So what can we do? How we should reshape the future now? First, we need to raise awareness on valvular heart disease. When you look at incidence and mortality rate of MR, it's very similar in France to the mortality rate that you can find for breast cancer. You have seen these large campaigns for Alzheimer, breast cancer, heart attack, or stroke. When we will see campaign on valvular heart disease? We see that a little bit emerging with some organizations like the Heart Valves in the US or in Canada or in Europe that try to sensibilize the population regarding what is valvular heart disease, what are the symptoms, and how important it is to diagnose early these findings. We need clearly to improve the screening. And the first tool for that is auscultation. It's fast, it's inexpensive, it's cost effective. The problem with auscultation is that you need some training and expertise, and you need to be focused on your auscultation when you do that in clinic. How we can help physicians? You have some AI process of computer-aided auscultation. In this paper, they have used computer-aided auscultation, so an algorithm to analyze the auscultation and compare the result of this algorithm to the result of the auscultation performed by skilled cardiologists. We can see that both for AS and for MR, the algorithm was performing very similar to a cardiologist. The problem with that is auscultation the best strategy to screen for valvular heart disease? I think it's not. If you look at a correlation between auscultation and echo, it has been done in the Valve study, is relatively poor. It's poor for general practitioners, but also not very good even for cardiologists. So we need to find another way to screen patients for valvular heart disease. One solution may be the point of care echocardiography. You know that we can perform now echo with a small probe and a small device the size of a smartphone, which is in fact a smartphone. And Dr. Sengupta has evaluated that in the setting of patients with rheumatic disease in developed country. It has shown that using POCUS, you improve the diagnosis, you improve the treatment, and it translates into an improved and a better outcome of the patient. POCUS has been tested in different settings, like here in the GP office, and the image were sent to a cardiologist same day for interpretation, or when the POCUS is performed, like in rural Vietnam, by nurses. The problem with POCUS is twice. First, you need to acquire good images, and two, you need to know how to interpret that. And again, AI will probably help us and give us a tool to have a better screening methods for valvular heart disease. In this paper recently published, they test 240 patients with POCUS, and all patients were scanned both by a nurse, helped with an AI algorithm, or biotech. And each nurses and tech were asked to acquire these 10 views in echo. Each nurse has to scan 8 patients. They had a limited training just before 1-hour didactic session how to use the ultrasound machine. And you can see that nurses were doing great with this AI process, and they were able to image LV, right ventricle, and other structure quite well. One issue is that the time to obtain these 10 loops were quite long, 30 minutes by the nurses. So the principle is exactly when you are playing a video games or when you are shooting with your plane, is to have an AI system that will be red when you are not aligned with a good view, going to orange when you are better, and show you the green light when you are in the good views and good incidents, and you just press the button to do acquisition. Second problem with POCUS is that you need to be able to interpret the images. And now you have the technology which enable us to share screen real time. So you can be in any part of the world, somebody is scanning, and you can be in your office looking at your screen exactly what this person scanning is doing. You need also to facilitate the access to echocardiography. And one of this model, the model can be to develop murmur clinic. I don't know in the US how easy it is to access to an echo. In Canada, it's especially in some area of Canada, it's very difficult. You need to improve access to echo to be able to screen patients. One way to screen patients, maybe an ECG, has been tested by this study from the Mayo Clinic. They have a large number of patients that had both an ECG and an echo. They use part of the population for training and validation, part of the population for testing. Results are presented here. It seems relatively good. Sensitivity 78%, specificity 74%, positive predictive value 74%, negative 99%. However, if you look more specifically at the result, so true positive 3%, true negative 71%. False negative 1% seems low, but if you look at it more carefully, you miss 1/4 of the patient with AS. On the other side, false positive 25%, meaning that you need to perform an echo to 25% of the population for nothing. So I'm not sure ECG is the best way to diagnose a patient with valvular heart disease. Biomarkers is probably the way to go. One limitation of testing biomarkers is that the tissue for both the aortic valve or the mitral valve is relatively limited, only a few grams, and as markers you are tested are released in 5 liters of blood. How we will be able to diagnose an AS MR signature is very uncertain. Another important question that we need to address in the future is when should I treat? And the secret is the timing. Now, for AS and for mitral valve, we are capable of performing intervention at very low mortality, 2% for TAVR, even if you're an elderly patient. And if you look at this curve that you can find in economy, for procedure, we are relatively here. Of course, you can improve the outcome of procedure. You can fine-tune everything. But the most gain that you make to improve the outcome of patients with valvular heart disease is to perform timely intervention, is a way to improve the outcome. In this study from the Impulse registry, we try to implement a small intervention. Just when the diagnosis of severe AS was made by echo, one of the nurses was calling the referral physician, just telling him that your patient had severe AS, you might consider, if clinically indicated, to perform an intervention. And we have published that. Unfortunately, we have a limited effect. We had an impact on the time to intervention, but not on the rate of intervention itself. And the best way probably to improve the follow-up and improve timely intervention is the development of valvular heart clinic. It has been shown in several papers that the outcome of patients managed by experts in valvular heart disease in the setting of valve clinic improves the outcome. And you need to perform early intervention. This has been shown in this paper again from the Mayo Clinic in mitral regurgitation, that if you perform early surgery compared to delayed surgery, the outcome is much better, both for mortality and for the occurrence of heart failure. And this early intervention has been implemented now in guideline for both ACC/AHA and ESC, that you class 2A indication to perform in asymptomatic patient with severe primary MR, normal EF, sinus rhythm, a valve intervention if the likelihood of mitral valve repair is high with a low mortality rate. What about AS? Now, still the recommendation is to perform the watchful waiting, which means to wait for triggers before referring a patient for with severe AS for an intervention. And what are these triggers? Triggers are symptoms and LV dysfunction. What happens if you wait for these triggers? First, symptoms. We know that in elderly patients, exercise is often not possible, so you may not unveil symptoms. Patients have symptoms, but they are subjective. What is symptoms? Symptoms are insidious and patients can self-limit themselves. So in the clinical setting, assessing symptoms in elderly patients with severe AS is often more art than science. Second trigger, LV dysfunction. We know that if you wait for LV dysfunction, less than 50 or 55% of EF outcome is worse than if you do the intervention around 60%. And the reason for that is myocardial fibrosis. You may have no symptoms, but you developed myocardial fibrosis, as assessed in this study by the extracellular volume fraction. And you can see that patients with fibrosis have a higher cardiovascular mortality and a higher mortality. You have all seen these slides from a Ross and Ball valve, suggesting that when you have AS, you are safe for a long period of time until you don't, when you don't have symptoms. And when symptoms occur, the prognosis is very poor and you develop CHF and you die. This concept is completely wrong. You don't have any precipice concept. You are at risk even if you don't have symptoms. And so in my opinion, waiting when you have severe AS is waiting for problems. And I took this quote from a self-improvement study. In addition to waiting for problems, patients are not getting younger and better every day. And I think we should rephrase this quote as a patient who is better now than it will be tomorrow. And performing an intervention at that time is probably better than to wait as the patient gets older with more comorbidities, more frailty. And in AS, we have the recovery trial, the randomized patient with severe AS defined by the valve area of less than 0.75 and a peak velocity of more than 0.4 or a mean gradient more than 50. And they were randomized versus conservative management, so watchful waiting or surgery. And the outcome is in favor of early intervention. You can see that both for total death and cardiovascular death, patients that are referred for early intervention do better. So like probably everything in life, it's probably better to do it today than to wait tomorrow. And we have ongoing randomized control trials that will tell us more regarding the timing of intervention in the asymptomatic severe AS, early TAVR, easy AS, and EVOLVE in particular. And when you need to do an intervention, you need to refer your patient with in a centers of excellence, the heart valve centers of excellence, which is the centers with high volume, capable of performing all type of intervention, both surgery and transcatheter, with excellent outcome. I'm sorry, I cannot stop that.
Code white, A alpha 3, code black,
So
alpha 3.
you want both centers capable of performing all type of intervention with excellent outcome. Like we say in France, you don't want cheese or dessert, you want cheese and dessert. And another critical problem that we face that should be addressed in the future is who should I treat and how? For that, I have shown you this study where we collected more than 400 patients with isolated tricuspid valve surgery, showing that prognosis was predicted by the presentation. However, it was not very useful at the individual level. And for that, we further refined that and we developed a specific score for predicting the in-hospital mortality of patients with isolated tricuspid valve surgery. This score was based on age, symptoms, consequences on the right ventricle, consequences on the liver, and consequences on the kidney. And you can see that the calibration and discrimination of the score was good. With 9 points, your risk of dying is more than 65% in hospital. Patient with functional mitral regurgitation. You're all aware about the controversies regarding the treatment of patients with FMR, with the mitral FR study showing no impact or no benefit of the mitral clip in patients with functional MR, and the COAPT trial showing that patients who underwent a mitral clip have a better outcome. My understanding of the literature is that COAPT is showing us that treating patients with functional MR with a clip improves the outcome in selected patients with functional mitral regurgitation. And ESC guidelines, the last release, is not saying differently, saying that transcatheter repair with the edge-to-edge, so the clip, in patients with severe functional MR should be considered in patients with fulfilling the criteria of the COAPT study, and that are close as possible to the patient enrolled in the study. We look at that in the sub-study of the mitral FR. We selected patients that were COAPT-liked based on the severity of the regurgitation and severity of the LV remodeling. And we didn't find that the clip had any impact in the patient that were COAPT-like. Even if it was post-op retrospective analysis, it raised the question is, how we can identify patients that are clip responders and that will benefit from the intervention. We need to better select patients that will need an intervention. I showed you that mortality under medical therapy was 60 to 70%. But even if you perform a TAVR in patients that are high risk for intervention, 40% are dead at 2 years. We need to develop techniques to better identify which patient will die within 1 or 2 years and avoid performing futility TAVR. And we need to define what kind of treatment should be the best for one patient. Now we can perform valve repair, like a band, or shooter lines like the Alferi, or mitral valve repair, or we can perform replacement. And it can be done by surgery, or it can be done by transcatheter therapies. The question that we face now is which patients should be treated with which technique. And for that, simulation is probably the best way to go. We will be likely possible to mimic the result of the intervention. So you can take the heart of your patient, do a modeling, and put 1 clip here, 2 clips here, and assess what will be the result. If the simulation is suggesting that you will not get a significant improvement in the degree of mitral regurgitation for clip, it's probably better to perform valve replacement. And again, simulation will tell you what is expected outcome in terms of mitral valve replacement. What is the risk of LVOT obstruction, for example? And finally, there is a critical need to better understand the pathophysiology of valvular heart disease. There is multiple ways of doing omics, genomics, epigenomics, transcriptomics, proteomics, and metabolics. It's critical to identify which are the pathways involved in the pathophysiology of valvular heart disease in order to develop medication aiming to preventing the progression of valvular heart disease. And we know it's complex. There is not one pathway. In AS, for example, you have calcification, but you have also fibrosis. And the fibrosis is probably the leading determinant of AS in women. For example, if you compare the degree of calcification between men and women for the same hemodynamic severity, women have less calcification. That's why the threshold for CVS by CT calcium score is lower in women than in men. And it has been confirmed that women have more fibrosis. And in this very elegant AI gene expression studies, they clearly showed that the gene expressed in the valve of the patient that are female and male are very different. So if you go back to this study on the inhibitors of bone remodeling performed the team of Edinburgh, it's possible that they have missed the population that may benefit from this treatment based on age, based on sex, based on the presence or not of osteoporosis, and maybe the degree of severity was not appropriate. So it's unlikely that we will develop one medication for everybody that will cure or prevent AS, and it's critical to develop individualized and precision medicine. One way to assess which population are at risk of progression may be functional images. For example, for AS, we can use a PET sodium fluoride, which has been demonstrated to predict the progression of calcification. And one critical issue we will face in the future is prosthetic valve degeneration. You have seen this slide, number of patients with TAVR and tissue valve is markedly increasing. And in the near future, we will face a lot of patients with prosthetic valve degeneration, especially as we increase the number of TAVR performed in low-risk patients and younger patients. So in summary, valvular heart disease is clearly the next epidemics. We are dealing with an elderly population with frequent comorbidities and clearly a suboptimal management. Patients are underdiagnosed, undertreated, they present late in the course of the disease, and there is clear inequality in the treatment of patients with valvular heart disease. So what we can do, we need to raise awareness of valvular heart disease, and this is the role of public and policymakers. We need to improve the screening program and perform early detection of patients with valvular heart disease. We need to better follow patients with valvular heart disease and perform timely intervention, and this is the role of the development of valve clinic. We need to have individualized and optimal result of intervention, and this better intervention will be performed in Heart Valve Center of Excellence and Precision Medicine. We may need to develop new device, like specific device for patients with Trichosphere Regurgitation, device for patients with mitral annular calcification. And more critically, we need to avoid intervention. We need to have medication that will prevent the progression of valvular heart disease and prosthetic valve degeneration. And grant agencies and industry have a critical role here. And I think I'm stopping here, and I'm really happy to take any question you may have.
Thank you very much, David. This was a fabulous journey through the whole evolution. I think you covered, I perhaps must have not heard a better coverage of a valvular heart disease than any other person in 40 minutes. This was one of the most spectacular presentations, and it was not easy. You covered everything. I really don't know of anything that you've left through. So let's talk about, I mean, you touched upon so many places, but let's make it more relevant. And I think we want to learn from you. I think the concept of creating a valve clinic is a great idea. But I'll start with you, and then we'll come back to the panelists. What do you think is the function of a valve clinic, and how do you think, if let's say if there was nothing in a place, how would you start building a valve clinic?
First, you need to have people that have interest and expertise in valvular heart disease that will see the patient. And when you need to organize the clinic in a way that all patients or most patients with valvular heart disease will be referred to that team in a centralized way. You don't have to have the valve clinic always in the tertiary centers. You can imagine that you have different degrees of valvular heart clinic in some community hospital, but you need to have people expert in valvular heart disease that are examining the patient, that are performing the test, that are following in a timely fashion patient with valvular heart disease, and referring in a timely fashion the patient for an intervention. So experts in valvular heart disease, centralized assessment of patients with valvular heart disease is probably the key.
So let me come back to you there. So what do you, when you say experts in valvular heart disease, so, you know, the typical way we are set up is you have cardiology colleagues or our colleagues in the community from family medicine, and they encounter a valvular heart disease concern, and typically their response is to directly connect to a surgical group or to directly go to an interventional group. Should that be the way, or should they, I mean, what I'm trying to come up is what is the central way to, or at least how are you set up in your place to uptake these patients, and because there's a lot that goes on in understanding these patients, and not everybody may need a surgery, or not everybody may, I mean, it's a different case when someone is presenting late, but if we have to go in a systematic way, how would you set that up?
So some patients are easy to manage, and you need also to differentiate if you are a GP or if you are a cardiologist. A patient with severe aortic stenosis and symptoms, you may argue what is the value of the valvular heart disease clinic. You may refer directly the patient to the TAVR or a surgery. What is important is most patients are, you mentioned that are referred late. What you want to avoid is that. And the only way is that patient that has been diagnosed with valvular heart disease, even if it's mild, moderate degree, is assessed by somebody with expertise in valvular heart disease that will follow the patient carefully until the time of intervention. I had one patient referred last 2 weeks. He was diagnosed with severe AS because he had a new GP that put a stethoscope on his chest, and the mean gradient was 90. He was 74, healthy. You want to avoid that. You want to avoid patient coming with LV dysfunction. Only way is to screen patient, and when the valve is diagnosed, to refer to somebody that will follow and have expertise. So it's maybe a valvular heart disease organized in an hospital, but it can be in a community, a smaller team with dedicated interest. How we have done that here? So we didn't have that at the beginning. It's not perfect yet. So we have both the valve clinic and some other physicians that are following patients with valvular heart disease. We are not following all valvular heart disease, but we try that to be available for any GP that has diagnosed with a murmur, or a patient that is diagnosed with any degree of valvular heart disease, to be there and said, send the patient to us, we will evaluate and we will follow the patient with you, and we'll tell you when we think is the best timing for intervention. So I think the best target is probably GPs. Model may be different in Canada and the US. Here, access to care is quite complex. You can wait sometimes 6 months to see a cardiologist, and to see a specialist, you need to go through a GP. So you cannot say, knocking on the door, said like we're doing in France, I want to see a cardiologist. It doesn't work like that. It's maybe different in the US.
So Dr. Sethi, so Ankur, in your practice, or what would you propose could be a way for us to move this paradigm of creating a center of valvular heart disease or a space? How could this work in the New Brunswick area?
I mean, first of all, that was a great talk. Thank you. Amazing breadth to what all you covered, and I actually a lot of questions for you. So I mean, I think collaboration and housing relevant physicians in the same workspace for that afternoon, or I think that probably one start. I think all relevant stakeholders, imaging people, interventionalists, cardiothoracic surgeon, probably house in the same physical locality to discuss that patient for that evening, which is referred by a clinical cardiologist. I think that may be one start. While I jump on to you, because I have a lot of questions for you. First of all, my fan question, which is the most common valve disorder? Because I can't figure this out.
Probably yes.
Because it depends upon what reference you read. Second question I had is, you had a very beautiful slide in which you showed in 2017, the TAVR took over SAVR in France, and it is very similar in the United States. Actually, in the United States, it was a year earlier. There is a data out of TVT registry that SAVR volume was exceeded by TAVR volume that year, and now it's the most common form of aortic valve replacement. But you showed there is what, if I'm not wrong, 10% of aortic valve stenosis people did not undergo or were not offered.
The impulse registry, yes. So in Impulse, we find that 20% between 2015 and 2017 were denied an intervention despite being symptomatic.
So are these? I'm just curious because I'm trying. We don't have. I don't think we denied that many patients. Is these patients because they were frail or they were not typical normal gradient, normal severity aortic stenosis? Because no, in my back,
they were all with true severe, yes. So mean gradient was more than 40. It was not the pseudo severe. So they were all with high gradient. Okay. But you are surprised. You look at the paper from the Mayo Clinic, the one published in the Lancet. patient had significant MR, so they live around the Mayo Clinic. They have access to care. They had an echo showing that the patient had significant MR. They are symptomatic, and they are not treated around Mayo Clinic.
Wow.
So
Okay.
you may be surprised. You may not think that you are denying an intervention to patient with ES, and I trust you, but here we are talking about global.
Yeah. No, I think the question I wanted to ask you was that I feel personally in our community, the patients who are not being picked up, or a frequency of patients who are being missed intervention, are not normal gradient, but the low flow, low gradient, or paradoxical and gradient patients, because they sit around in the community or they get an echo, it's not picked up. So what do you suggest, or how can we structure our echo report so that we pick up those patients and they are being referred to relevant?
I don't know if it's efficient, but you can mention that, and I'm writing that now, consider referral to the valve clinic, because what you mentioned is that your echo is done and is sent back to the referral cardiologist or GP, and the report is sitting on the desk and they don't know what to do. So the only way to improve the care of this patient is to take this patient in the valve clinic and reassess the patient. You do calcium scoring, you do the vitamin echo, and you decide if the symptoms are related to ES, or maybe it's amyloidosis, or it's non-severe ES. But if you just do the report and send it to the referral cardiologist, the patient will be denied intervention. And that's why we have 20% of patients denied intervention, is that they were severe ES, you send the report and said, okay. And we have seen as well in the survey performed by the ESC that the knowledge of the physician is clearly insufficient. So the patient, the echo is sent to the physician, but the physician does not know what to do with the report.
Yeah, and in that, I think I wanted to mention, and David, you participated in this multi-center study that we did using automated AI approach, which is able to take in some of the numbers and make a better sense and create a little bit more concern about higher likelihood of this being a significant aortic stenosis. I mean, the point I'm saying is, I'm not saying moderate or severe. I'm just saying this being an important, significant aortic stenosis. So that actually, something like that is going to it could be used and inserted. This could be a aortic stenosis of significance. Consider getting it evaluated. I mean, the idea is that even moderate aortic stenosis, for example, I mean, it's not benign. I mean, there is more and more concern about what is true moderate aortic stenosis is probably difficult to define, because there's many of those, in fact, are significant aortic stenosis. I think we will come to know. There's going to be more and more literature around that. Yes, David, you were saying something.
No, I agree. The first step is to have a reliable way of assessing patients. You need, when you have SAVA, you need a good echo lab to be sure that everybody is making a mistake, for sure, but that when you are saying that the patient has a gradient of 20, is not a patient with a gradient of 40. You need a careful evaluation of the severity.
Yeah, and that point brings me to an important question to Saba. Saba, how do you create a good echo environment? Because there are so many pressures, right? It's for valvular assessments, it's basically more time. And in fact, I don't know, David, how do you do that? But we often find that we have all the studies that we have to do, and the amount of time that requires for a patient to be enrolled in the studies, and the TE and the number of clips that are required are disproportionate to what is needed typically in a routine clinical practice. So, Saba, what are your observations? I mean, and what are the challenges?
Yeah, so I just want to start by saying thank you to Dr. Nasika Zaitoon for a very comprehensive review of valvular heart disease. You pretty much touched on everything in a very short duration of time, so thank you for that. I think, with all the exciting advances in technology in valvular heart disease and transcatheter interventions, we've come to realize over the past few years that it's critically important to have good imaging in order to select patients, to pre-plan these procedures, intra-op guidance, as well as post-procedure complications and picking up of those perivalvular leaks. And I think, that's, what has happened is we've noticed that there's definitely a deficiency in the workforce. This is not an ACGME accredited fellowship here in the US, and there are very few programs around the country where you can actually go and have training in structural echo, for example. So one of my questions to you is, how do you, deal with this in Canada? Is there a specific track that you have for training? And at least what we have done is typically try to hire people who are, have completed an additional year of echo after their cardiology training. But even with that, I think there's more and more a need for getting people who are specifically trained in structural intervention echo. So I'd like to hear your thoughts about that.
I agree. Structural echo is a subspecialty of echo. It takes time and expertise. You need to spend hours in the cath lab and interact with interventional cardiologists to learn. We don't have a specific training in Canada. Some centers are offering, let's say, a fellowship combined 1 year of regular echo, 1 year in the cath lab. We don't have that here, for example, but some centers are offering that. Most of the time you learn by being in the cath lab and interacting with interventional cardiologists and listening to the other people guiding the intervention.
Right. I also want to go back to 2 points. Ankur, one was your point about the low flow, low gradient cases. I think in our reports, we like to point out that the ejection fraction is reduced, and then always we put in that phrase, low flow, low gradient, at least moderate. But I also wonder sometimes how much of it gets lost in translation if the person receiving the report is, family medicine physician or primary care physician. And so, we haven't been saying, consider referral to valvular heart disease clinic, but that may be something worth looking into. And coming back to Dr. Sengupta's question, we have implemented several quality control processes, such as when one of the sonographer goes and gets, using PDOF imaging, gets a gradient, and it doesn't match with the aortic valve area, we usually have 2 sonographers go back. That's based on the Duke buddy system and many other such processes. But we want to make sure we're not missing this case from a referral standpoint. Once the report goes out, I'm not sure that we're capturing all those patients.
So to answer specifically your question regarding low gradient AS, I think what is critical is to mention that you may underestimate the severity, and you might consider another modality for assessing the severity, especially, and I read that in my report, usually when the valve is heavily calcified. When you have a bad valve and the gradient is not matching with what you see in 2D, I write, consider another modality or another referral to cardiologist. And I'm sorry, I didn't remember the first part of your question.
There's so many questions, David, that you're very inspiring us. But one thing which I really want to come back to about the idea of the valve clinic. But imagine if you want to screen, right, and you want to use something. Imagine if you were So if you everybody above the age of 50 has a colonoscopy, right? Everybody at the age of certain age should have a pocket ultrasound or an echocardiographic examination. We don't have that as in guidelines, right? Why not? So I think, as a health system, Ankur or Saba, and with people, experts like that, maybe we need to create a campaign, right? And start doing a pocket ultrasound exam for everyone, right? Once he's above certain age, let's say 60, whatever you want to call it, 60, 65, 50, it's not going to be bad, because even if you have something detected, right? And as an extension of stethoscope, it's not a bad idea. And I feel like, I'm not saying do the whole pocket ultrasound. 1 or 2 views, let's say, this is out for open, 2 views. Plaques gives you a lot, right? You get an aortic valve, you get the mitral valve, we get a little bit of the ventricle, and maybe 1 more view. Plaques for everyone, right? 1 view. And
With color.
Color, with some color, of course, with some color, right? And one more. Which other view did you say, David? If you were to choose.
I said with color as well.
Yeah, with color. Yeah. So because what we found in those studies that we did in India and other places, you detect valvular heart disease are not difficult to detect with pocket ultrasound. They come very quickly. I mean, you may not estimate them correctly, but you can detect the presence or absence. So maybe that's
a great idea.
Yeah.
I also think it's a great idea. It would be like a community-wide screening program, and the question is funding. How to get it funded, but it would definitely be something that can be implemented at the community level.
Yeah. So, and I think Sabah, think about maybe now there are some pocket ultrasound companies. They're already you don't need to scan. They can help you scan it, right? So like I think what is that company? There are some vendors that they are doing.
Caption.
Yeah, Caption Health, correct. Thank you. And imagine if you had a deep learning for presence or absence. I'm not even saying, and let's keep the sensitivity low. We are highly sensitive, may not be specific, but at least we get alerted not to be able to. We'll capture all the severes, at least. I'm hoping. But why not? I mean, there has to be some urgency about this, because I think what Ankur and myself, we always see all these late presentations and with lots of comorbidities and very, I mean, it's not a lot of fun to take them through. Not that we cannot do it, we can do heroic things, but I don't think it's really adding up at that point. I think you lose a lot of the survival benefits that you could have offered. So, I mean, I really thought about that, and really I'm motivated to think about something like this, and maybe we can fly you in.
We can do that in US and in Canada jointly.
Yes.
Would be great. One thing you might think of is that the patient may screen himself.
Oh yeah, actually you told me very correct. Just like you do self-examination, like mammograms.
You can put a probe. If you have a good AI system,
yes,
you can imagine that you have a box, let's say in the supermarket.
Correct.
The patient is just opening his shirt. He puts the probe on his chest, and you following the AI said move left, shift up, down, and you get the two views, and you screen yourself in the supermarket, like you take the blood pressure at Shepherd Drug Mart.
I mean, we could think about the supermarket, or maybe we can just create some rooms and booths for people to come and take their own exam before they walk into their clinics, right? I mean, so that we don't have to spend time taking their pictures. So we don't need sonographers.
But supermarket is I was thinking about supermarket because
supermarket
everybody is going to the supermarket.
But the problem would be the privacy issues of.
No, if you have a small box, you enter one by one. With COVID, it's more complex because you have to clean and everything. But
great idea. It's a fundable idea. I think we just need to get to some big source to get the funding done, and I think it'll be wonderful to think through. But anyways, it's almost 12 past 6, so we really stretched our limits. Unless there is any burning question, anything from you, Sabah, Ankur?
No, I think one more thing I'll really quickly mention. That there is one difference between, actually there are a few differences between European and American guidelines. For the particular thing why I want to mention is the asymptomatic aortic stenosis. There is a leeway to intervene in both European and American guidelines. They have cut down the velocity from 5.5, I think 3 years ago in European guidelines to 5 in the most current iteration, which is still a little bit higher than the recovery trial, which is 4.5.
You can just give us a little bit of whiff of contrast and make it 5, no?
Yeah. I think the point, but the key difference is that in European guidelines, any intervention, surgical or transcatheter, is allowed, but in current American guidelines, only surgery is allowed. So I just want to bring this up that because we are currently actively recruiting for early TAVR as for asymptomatic AS patients. So I know there are a lot of cardiologists on the thing that if there is an asymptomatic aortic stenosis patient, he can be potentially randomized to early TAVR trial so that we can make TAVR as also a class 1, 2A indication, or at least hopefully one indication once this trial is concluded. And we also have an active moderate AS trial for which we are recruiting patients.
I just want to go back and add one quick point to Dr. Sengupta's point about the valve clinic. I think we would need to have a surgeon on site, a structural interventional cardiologist, an imaging specialist, sonographer, obviously echo machine, possibly a bike echo to look for pulmonary hypertension related to mitral stenosis. And so having that combination of the equipment, but also those specialists would enable diagnosis in a comprehensive way, but also come up with a pre-procedure plan and maybe even schedule right there.
Yes.
I'm not sure about that model. It's debatable, but I don't think you need to have everybody seeing the same patient at the same time. If you have one patient can be with AS can be seen by an interventional cardiologist, an imaging specialist, or a surgeon. Sometimes decision is easy. And after that, you have a second layer when you have complex patient. And this complex patient can be discussed as a clip round or as a TAVI round. But I think you need to have different layers. You don't need to have a room with a cardiologist, a surgeon, an imaging specialist seeing all the patients. I think it's going to be impossible. You need to have the first layer. You do the first triage. They are easy case. This guy is TAVR, this guy is surgery, this guy needs conservative management, we follow. And you need a second layer, which is the clip rounds, the TAVI rounds, where you discuss complex patients. And
I think that's a good point. I think sorting them out according to complexity, but for the most part, I think I was referring to the more complicated, cases. Obviously, the straightforward SAVRs are going to go to surgery, but the elderly patient with mitral regurgitation who could be a candidate, for one of 3 or 4 procedures, or maybe even a clinical trial, probably needs to be seen in a more comprehensive setup.
But you need first to have the patient has been seen by somebody expert in valve, confirming first that the patient had severe regurgitation, that he needs some things to be done. And after that, you can discuss as a group how you do it, if it's a clip or it's a surgery or transcatheter mitral valve replacement. But you need the first layer to assess the patient clinically, to confirm the severity, to confirm the symptoms, and confirm that the patient needs something done. And after, you can, as a group, discuss how you do it.
Yeah. So lot to digest and lot to get this through. And I think in the next 1 or 2 years, David, as you know, that we are just developing the whole division, and we are right at the inception right now. So all these discussions are wonderful because it throws and seeds, provides the seeds of the changes that we want to bring in. And we are starting a little late here in the sense, but I think this is a good, because there's so many digital tools we can use in this process. There's imaging that is really galloping, and there's a lot to get through in the communities as well. So I think I really like the ideas.
You need to adapt to your own environment. For example,
Yes.
in Canada, our specific difficulty is access to care.
Yeah.
It's a big problem. Access to GP. Some patients cannot have a GP because there is nobody available, which is crazy. And access to cardiologists is not always easy, even in Ottawa, and it's even worse in rural countries, like up north. So access is a big problem in Canada.
Thank you. Next time when we have this discussion, we'll get a glass of wine on with each one of us. So
And you're welcome to Ottawa.
More than 1 hour.
You're welcome to visit us.
Ask you a lot of questions.
Yeah, great. Thank you very much. All right. Good night.
Thank you.
All right.
Thanks again for the invitation.
Thank you.
Thank you. Thank you, David.